Good evening, everybody. Early evening for me. I know for some of you it's late evening, might probably dark if you're on the East Coast. I'm out here in Arizona, so it's still light around. I'm looking forward to some fun this evening. I'm going to be talking about demystifying occlusion, which is a real fun thing for me. So let's get some logistics out of the way at the very beginning. Desi is here with us. There is a Q&A that you can go to the bottom of your screen and click Q&A and enter a question. She's going to be monitoring that. And if it seems like something that we should stop for, she's going to come in, jump in and stop me. Otherwise, when I get to the end, I'll stop sharing and I'll be able to look at those and I'll go through whatever people have put in there. Um, I called this demystifying an optimal occlusion. And the reason for that is that optimal occlusions are the ones that work. And that's kind of always been how I came to understand it. And I lived through the occlusion wars. When I was young, there was lots of argument going on. And one of the best questions I ever heard posed about that, was this one. Excuse me, let me just clear that. What questions do we need to answer about an occlusion? What are we after? And these are the things that I thought of. Can I use the patient's existing occlusion and be successful? In other words, if I see something like that, can I use the occlusion they presented with and have it work? So I need to know a lot of stuff because there's a lot of stuff going on there. As it turns out, this is somebody who has been self-adjusting their occlusion for more than 20 years, a dentist. And so I probably can't use that one because it still doesn't feel right. And that kind of leads you to the next question always. When must you equilibrate? In other words, when do you have to go in and try to help things work better? The big question in that one always is if I change the patient's existing occlusion, what's going to happen? And it's why we always talk about why we think things are causal. Well, we can talk about that one all day, and that's really not the topic here. I want to talk more about making teeth work. But we can make teeth work better together by just understanding the mechanics. The ultimate question, of course, is if you jump in and change everything, how do you recreate it? And I've been doing this for a long time, and there's still that little thing in the pit of my stomach that when I cut away my last occlusal contact is always there. Now, when I was younger, I was really just after the one right answer. And when I was younger, these were the kinds of things that were being talked about. All of these, gnethology, neuromuscular, bioaesthetics, and then what I lumped together as Pankey Dawson because there were several. But the truth was this, if I looked out there, it seemed like multiple approaches to treating occlusions proved to be successful. They would all work. And if they all work, which one should I use? Maybe we need another question. And this was one of the best questions I ever heard asked. I first heard it asked by Dr. Frank Spear in the early 1980s. And he said, maybe the real question is this one. When is an occlusal approach not going to be successful for an individual? In other words, if you're seeing something in someone's mouth and it is not working, that just told you that it isn't being successful. So what do we think about with that? And what does it look like when that is happening? Both all four of those, and including this one, which is maximum intercuspal position, which is where people function, where their teeth go together. And those are outside of the realm of that sometimes. It kind of depends. In fact, lots of times it's within one of those, but it's not, if you will. These are the kind of things that happen. You have signs and you have symptoms. Okay. I'm going to say that symptoms are the things that are showing up on the left side of your screen. Symptoms are things patients can experience: pain, sensitivity, joint sounds, loose teeth, functional limitations. And then signs are things that we can see: wear, cracks, fremitus, mobility. We test for those. Patients aren't always aware of those kinds of things, but they're the things that tell us that something is not working. Classical occlusal thinking always was this, at least the way that I learned it. There's one ideal occlusion, one right occlusion, one natural occlusion, and that's that one, because that's where I was learning this. Centric relation is consistent with intercuspal position. So that became my occlusal thinking. I believed that I should be helping people get to that, which means if you came to my practice, I would examine you. And if your occlusion didn't match the right occlusion, you were going to get treatment. That treatment may have been very successful. It might even have been necessary. And truthfully, what I found out later was there were probably a lot of times when changing it to what I believed was the right one may not have been necessary. Because let's think about this a little bit if we look at some of the numbers. Centered relation equals intercuspal position 1 to 19% of the time, multiple studies. They range in that. They found in some studies 1%, up to 19%. So why don't we say this? I'm going to go all the way to the top and I'm going to say, look, maybe even as much as 20. That means that for 80% of people, it doesn't. 80% of people have a first point of contact and a shift from centric relation. And then we could have a discussion about that because there are several definitions. That actually, interestingly, I think there are 9 total listed in the glossary of prosodynamic terms. And the first one and the one that is currently number 9 are actually very close to the same. People have been struggling to figure out a definition for that for a long time. But I think it's fair to say that if 80% of people at this seated condylar position that was named centric relation, okay, and it was supposed to be a fully seated joint position that could be repeated, that 80% of people will touch somewhere and have a shift until all of the teeth fit. 80% is a strong argument for normal. And so here's the truth. Multiple approaches have proven to be successful, not just that one. Other approaches work. In fact, most dentistry is done at maximum intercuspal position in the world. And a lot of that dentistry lasts a pretty long time. Why is that? It's because of this. Human beings are adaptable organisms. When does adaptation begin? It actually begins in the uterus. You adapt to whatever the environment is that is being created as you develop. Adaptation is occurring. That goes on until your cells stop functioning, until death. You always have some range of adaptability. If your ability to put teeth together and function with those teeth for what they were designed for is within your range of adaptability, you're going to be asymptomatic. It's going to be working for you. Now, there might be some signs, and I would argue then that you're not yet outside of it necessarily because you would keep working with it. As soon as you have symptoms, that can change. You begin to try to alter things yourself because that leads your adaptive response. Okay. If it's outside the range, then you're going to, when you get symptoms, those symptoms can cause dysfunction. There's a problem with adaptability. Adaptability is highly variable. Patients have very different thresholds, and it's not just as individuals, it's one individual. It can change over time. If you think about something like this, here are 2 things that we know will kill you. It's pretty clear that we know the dangers of these 2 things, and yet there are some people who never have the negative consequences of these over years and years and years, and that has to do with their adaptability, their response to this input or this stimulus. And again, that range of adaptability, though, can change for people. And it does change over time. If you're old enough to have been in practice long enough to have kids kind of grow up in your practice and then head off to college, many of them come back and they have a temporomandibular disorder. In other words, they have jaw joints that hurt. And what they have done is they have done something that changes what they're doing and applying force in a way that has exceeded their ability to adapt without having symptoms. And therefore, they come back and they tell you, yeah, all of a sudden my jaw joints are sore. I'm sore. I must be grinding. They're doing something. And that their range of adaptability changed. Okay. In other words, the range was when they weren't doing things, they were well within that range. They changed it. Boom. They're outside that range. Okay. So as they experience that, the range is what causes you to have and experience the change. These are the things that happen. Sometimes, if we can find a way to make teeth work better, we can bring people back into a range that is not outside their adaptability. Now, I'm not talking here about cause and effect. What I'm talking about is that's what people can do with their teeth. We can manage that and create something that is more stable and very often move them back into an adaptive range where they don't have the same symptoms. That does not go to the core about why they're doing what they're doing. Now, the upshot of all of this stuff is really the fact that all occlusions are highly individualized. For that reason, highly individualized occlusions are what get created by adaptive beings. And it's why you have patients who have what looks like it shouldn't work, and yet it does work just fine. So our belief in this is that the first thing we got to do is we got to look at things. We have to be able to understand these three systems: joints, muscles, and teeth. What kind of things do we look at joints? We this, and by the way, this is not the topic of my conversation tonight. It's about making teeth work, but these are the things that we have to do. If we don't see things, we're not going to know how to correlate. And correlation is a big part of making teeth work well. We got to understand where the disc is. Okay, and what is it doing throughout movement? Where does it sit in there? How are people applying force that might cause some of the symptoms that they exacerbate when they put teeth together? What muscles are tender, in other words, or hurt? By the way, pain for me is a response when someone comes in and says, "This hurts." Okay, so they point to their masseters and they say, "These hurt, it hurts here." Those are painful masseters. If I have a patient who tells me, "Well, no, nothing hurts," and we go in and we palpate and they say, "That's uncomfortable," that's a 5 out of a 10. Those are tender. And the purpose of that is understanding how the patient is experiencing the symptom that I just created, because I created that symptom. In fact, I've had patients say, when I ask, "Why do you think that hurts?" "Well, because you pushed on it." Now, what movements are limited? Restrictions in movement have to do with how people can apply force, because muscles will try to protect themselves and other structures from hurting. What function is altered in those movements being restricted? Muscles will align the teeth into a maximum intercuspal position. Most of the time, you're going to train yourself to bite down and you'll hit on these teeth. You learn that because that's what works. If teeth were not there and those muscles fired, then the mandible would always move to some seated position. And again, that's been called centric relation. And again, because there are so many definitions, I'm just going to say that it goes up, the condyle moves up into the fossa into some position that those muscles are pulling it to. And it is seated somewhere. Okay. In my belief, it's going to do that no matter where a disc is. And so, therefore, if a disc is in a proper position, interposed, I guess we could call that centric relation, is my point. But a fully seated condylar position is going to occur anytime those muscles fire and there's nothing getting in the way ahead of the condyles. Okay. And therefore, what it would look like if this was a person who had a first point of contact and a shift, that would be back. They would go back and they would go up. Now, normally, when this person would close, they would touch somewhere and their brain would learn an engram so that they would now go there. And again, for at least 80% of patients, we know there's a shift from that seated position to a maximum intercuspal position. This is not something they hit all the time. In fact, they rarely hit it. Some patients, we find a first point of contact in our exam, there's no wear around it at all. They're not going there. And it's because the engram tells them just fire muscles that allow teeth to do this. And it does that. And while I'm going to pick out the lateral pterygoid and anterior temporalis because they're the primary positioners, all muscles are firing whenever we're positioning anything. Okay, now that means that making teeth work together, I think, can be accomplished lots of places. And making them work together better isn't necessarily going to cure some issue that was created, because I still don't know for sure why they're doing what they're doing. So let's think about this and look at teeth then, because teeth themselves will suffer consequences when forces are applied. Where is the sensitivity occurring? Where is the mobility occurring? Where are the cracks? Where are the fractures? Where is the wear? Those are the things that can lead us to what's happening to teeth. And when people apply force across their masticatory system, it's either the teeth, the muscles, or the joints that will suffer consequences if those occur. In other words, if we exceed the adaptive capacity. So people can put their teeth together generally in 4 places. A maximum intercuspal position, everybody can go there. And by the way, a variable number of teeth are going to hit. I have had patients were patients in my practice who had variability of anywhere from 2 teeth contacting to 32 teeth contacting in MIP. And these are people with full dentitions. Okay. And some in the one who was the two teeth touching, that person could only hit those two teeth in all kinds of movements. You couldn't get other teeth together. Okay. Second place, excursive pathways, anterior or lateral to MIP. In other words, you come forward from that position where everything fits together and or lateral and actually a mix of all of that. It's all of the movements that occur once the teeth are touching each other. And then once they're out on the edges at end to end and crossover, they move past the front teeth or they move past the canines in lateral movements. The fourth position, there's up to 20% of people, and I decided to call it 20% as I told you, up to 20% of people, but I'm going to say 20% of people have occlusal contacts retruded from a maximum intercuspal position. In other words, their condyles can seat and go back, and when they go back, they have a different set of occlusal contacts. Usually, those are going to be more posterior because that's how the mandible works. What happens at maximum intercuspal position? We chew food there. We swallow there. Some people clench there. Excursion pathways. Okay, what happens there? We chew in those positions. We actually, especially the lateral ones. We speak there. A lot of sound is made by positioning teeth somewhere in those pathways. And then there are dysfunctional things that people do. Bruxing, grinding, for me, there's bruxing is kind of a central nervous system thing. So bruxism is going to occur because of a central nervous system stimulus, and I would call that bruxism. And then people can also do what I would call parafunctional activities. And those, I don't yet know exactly why they're different, but I think they're different if we could say that. In other words, I think that parafunctional activities seem to be more affected by how you alter how teeth work, because I've seen people stop grinding, whereas central nervous system mediated bruxism is probably not going to be impacted by how I make teeth work because they're doing it for another reason. And this is a fun one for me. The more I've learned about breathing and realizing that people will brux to be able to breathe better, I'm going to call that a functional activity. They're trying to breathe. They happen to brux so that the muscles will fire and they can open up that airway. Okay. The end to end and crossover, here's edge to edge or end to end. And as you slide around here, if you come forward, you're going to go past into protrusive crossover and visualize the lower anteriors moving forward and coming in front of the upper anteriors. So they drop in behind. And then crossover is when we shift to one side or the other. So in lateral crossover, the mandibular canine crosses over the maxillary canine, or it comes out past its edge. And in a lateral movement, they would still be touching. I just did a slid it out across to show. Same thing when it goes the other way, okay? What do we do there? Well, we incise things. We bite things off, shear. We speak there. We make a lot of sounds. And there are dysfunctional things that people do. Some people wear their teeth in edge-to-edge positions. Some people come out and grind in those pathways until they get to the edge, and then they lock in there and they apply just force because they can lock in places. And I'll show you a case with that kind of an angulation and a lock-in and show you the pathognomonic lesion of crossover. What about occlusal contacts retruded from a maximum intercuspal position? Well, if there's a seated joint and I have a first point of contact, and that's what you see illustrated on the image right now, the teeth that are going to touch first in this case are the most posterior teeth. The most common contacts when someone seats and has the first point of contact is going to be in the molars. The second most common one I find are maxillary first premolars against whatever is touching them. So usually either a canine or a first premolar. And in this case, it's the molars that touch first, okay? That's what has been named as centric relation. For my definition, then, this contact becomes what I would call centric occlusion as opposed to maximum intercuspal position, because this is the occlusion at centric relation. That's a definition that has changed over the years. So if you're reading literature, you need to know if they're using it as MIP, which it used to equal years ago, or if they're using it, as a first touch. In other words, the occlusion at centric relation. So these are the teeth that contact there. Those are retruded contacts. What do people do back there? Well, actually, a lot of people chew there. A lot of people swallow there because they'll close there and they do some functioning there, even though they can shift forward and get teeth together. And then there are dysfunctional things that people do, and I'll show you a case of that. And I know that you've got these cases. This is where they can isolate those teeth and they can put it extreme wear on those teeth. If you see the first point of contact in these teeth, they are always surrounded by a wear facet if the patient is going there and isolating those. Okay. So here's our process at Pankey. Let's think about it this way. What we want to say is let's make a diagnosis of what's happening with the current occlusion. Is it physiologic or is it pathologic? Now, if it's pathologic, I hope that what we would be thinking is, well, I'm seeing some of this stuff going on. And so my first question will this occlusion work? Is going to be no, it's not working for this person. Whatever's going on and how they can put their teeth together isn't working because the teeth are showing the impact of what's happening with that. Okay. I have to ask, how am I going to alter it? How am I going to alter this? Because that's not going to be it. Now, I did assume something. I assumed this patient wants to keep their teeth for the rest of their life, which is one of the questions. I have never worked with a patient that I have not had the opportunity to look him in the face and ask him that question. Are you planning on keeping all of your teeth for the rest of your life? And we have a wonderful conversation because I have had all kinds of answers to that, including, well, no, that's why I'm here, which some of those were really fun and interesting conversations. I liked making dentures, and people sometimes came to me for dentures who, in my opinion, could have chosen not to have dentures. Now, if the patient's current occlusion is physiologic, this is the question I'm going to urge you to ask yourself always as the first question. It's the one that I've trained myself to always say, why would I ever alter it? In other words, it's working. The teeth are there. It seems to be working. Things are not being destroyed. I'm not seeing that happening right now. In other words, there is some level of orthopedic stability when those teeth function against each other because they're not being destroyed. Why would I alter that? Now, there are a lot of reasons why, but I hope the first question you ask is that one. That will help you back up a little bit and say, well, if I change this, what am I affecting? Because my belief is that when I was first learning, I thought that just the fact of touching and shifting to that contact that was now MIP from one that was fully seated condylar position or centric relation, as I had called it then, was something that was needed to be changed. And today I don't believe that as long as that patient is physiologic, it's working. Now, here's what comes up for us very, very often as dentists. They need some dentistry. And if they require dentistry, they have pathology in the dentistry and an occlusion or the way their teeth function together that seems to be physiologic. They're not really destroying things. And there are a lot of reasons why people would need dentistry. Decay is a good one, and have what could be a physiologic occlusion. So here's the question that now has to come to the forefront. Where am I going to alter that occlusion? Because if I'm going to go in and do dentistry, anything that goes to an area of the tooth where one tooth touches another is altering the occlusion. And then I have to ask the question after going through that thought press for myself, why would I want to own somebody's occlusion? In other words, when do I have to be considering directing what's happening there? And when should it be dentist directed? Well, if it's pathologic, for sure. That's when the patient's adaptive capacity is exceeded by the rate at which the signs and symptoms are progressing. In other words, it's past that. It's already causing change. And here's the most important addendum to that I have added in the subsequent years in my learning. And the patient is ready for that. In other words, when the patient asks. And one of the favorite things that I learned, from Mary Osborne is please find a way to wait to be asked to do the dentistry. Can I stay in the question until the questions come from the patient? That also slows me down. And slowing me down is a really good thing when we're dealing with this. I altered thousands of occlusions, and as I said, some of them actually needed it. So if it's pathologic, I believe we have to own it. Ownership is also indicated when the changes to the teeth required for the dentistry they need destabilize the first point of contact and the shift to a full occlusion. In other words, I'm going to be doing some dentistry in an area that they would have touched on in the arc of closure. No wear facet around that, but I'm going to change the engram by default now. So I need to go check that. And I'll talk about that in a second. If it's physiologic, I'm going to leave it unless there are other compelling reasons for me to consider altering it. So, will the occlusion be destabilized by the planned dentistry? Whoops, I'm sorry. Is the question for this one? That's the variable. So, if the joint is seated, there's the first point of contact. Okay, there is MIP. We're doing that dentistry. If we're doing that dentistry, will that be stable when it's done? Because I have changed first point of contact, and if I'm changing all of those teeth, I'm going to change subsequent things, even if I make it hit everywhere at MIP. So this is a case of Frank's that is a wonderful case. It's a dentist. He's 56 years old. Don't like my front teeth and want to lose my amalgams. Completely comfortable, no muscle tenderness, and no wear. There are not any worn out teeth here. This person doesn't go do stuff with these teeth. Okay. There's a couple little spots where we're interdenting here, but they are bilaterally symmetrical, and I believe that those are genetic developmental. Okay. Here's the mount at a reference. Centric relation is still a really useful tool. For me, it has become a reference that I can plan from. And so always look at what's there. Today, I do my scans when I do because it's so easy, I scan all of my new patients. Plus, it's a great occlusal photograph. And I scan and my relationship is going to be captured at whatever the first point of contact I discover is. So I have that in my references. And so I could always reproduce that in 3 dimensions if I needed to actually look at it and thought that I wanted to do something. Because for me, sometimes feeling it is going to tell me things that I can't learn on the screen. I'm learning though. Excuse me. It's always mount at the reference. And in this case, that means these are the teeth that are touching in that reference point. There are 3 areas that are first points of contact. 2 of those are going to be altered by the treatment because we're going to be changing those. There are some cracks in the amalgams, and those are going to be onlays. So if those are going to be onlays, I am counting on one pair of teeth contacting each other to reset an engram. Will that work? I don't know the answer to that. I'm going to argue just because I've been doing this a long time, probably it will work. I think most of the time it works because someone who had an established MIP and seems to be functioning there usually does pretty well with that. Okay. Um, in this case, this is what you see. Okay. Now, there are the teeth. Here are the teeth that will be left where they could be contacting each other after the preparations are done. And there is where the engram has to be developed. Now at MIP, you're going to have all of these dots. All those dots occur because you come forward a little bit. Because this is the dentist asked, can't we just treat this at MIP? I go there. I've been doing it for years. It's totally comfortable. I haven't destroyed my teeth. The only place I have anywhere at all is on behind my front teeth, and that's pathway. And that actually in that pathway, some of it was material. I had some composites on there that, as you might recall, older composites did not hold occlusions very well. They wear quickly, and so they got into the enamel. Anyway, patient went home after everything was hitting just like this, all of these dots, plus dots on all of the provisionals, and here's how they came back. Where those other 2 dots were, those provisionals have been pretty much destroyed. Okay? If you look at this is in the forward MIP position, and this is at a fully seated condylar position. In other words, MIP is where everything worked forever, for years, for 56 years. And for 56 years, well, whenever the teeth came in and aligned themselves, so not really 56 years, but let's go with 46 anyway, probably. Okay, this is what they started doing as soon as that was altered. They could not find the place to go back. And what he wound up doing was breaking those teeth for that reason, because that MIP is no longer something that he goes back to. He didn't reprogram the engram. Okay, so those 2 dots were gone. It took more than that one to create the same pattern for the brain to fire and say, just go and do that. So what you have to do is make the teeth work in that seated position, which called for rethinking the case to now create a functional occlusion that would work. Because in this case, you now have to go to that seated position so that those teeth cannot be isolated. In other words, the risk when you use an existing MIP is that you will disrupt the engram programming and change how force can be applied across and will be applied across the teeth that now can be isolated. And that's a risk. So you have to check that and then talk about the risk factors with patients. This is what I'm observing about how you function, and talk about what might happen. I've found that if I'm willing to talk about what might happen, lots of patients are willing to undertake a learning pathway with me. If there are more teeth involved further to the back, you have higher risk. If there are few teeth and you're closer to the front, there's less risk. I mean, for instance, if I'm doing veneers that do not go all the way to the lingual, now I realize in the anterior I might be on some marginal ridges, but the form of the tooth on the lingual is going to stay the same. Where have I changed the occlusion if I elongated those teeth? Well, I changed it in the end of the pathway, usually in the protrusive pathway, lateral if I included canines and elongated them, and the edge position. That's what I changed. Now, those positions actually apply much less force, and they're all the way in the front. And so the risk is much lower with things like that, that I'll disrupt the engram. I haven't disrupted what happens in the back. Sometimes I decide I have to own the occlusion. How should I design it? Whatever the reason that I decide now I need to own this, what kind of things do I have to think about when I'm doing design? And here are the things that I think about. It's that intercuspal position, it's end-to-end and crossover, and it's all the pathways and patterns between those. In other words, any way they can put their teeth together. So here are the components of a designed occlusion. The reference position is going to be one that I have chosen based on whatever I have to work with. And the reason I'm saying that is that the condyle disc is appropriately positioned wherever it's positioned. Now, if I'm working at maximum intercuspal position, it's hard for me to get that record using only the joints. If there's a first point of contact and a shift forward. In other words, I need teeth if I'm going to not use a seated condylar position, because they become the things that I can anchor something on. I could also figure something out using an appliance. I could have somebody get really comfortable on an appliance. I could then mimic an occlusion, and then I could use the appliance to position where I want teeth to touch each other. Okay, wherever I've chosen to be my reference position. And that's why it says condyle disc appropriately positioned. And again, this is not a discussion about centric relation. I always record a fully seated condylar position as a reference, but I don't always go make teeth work there. And that's what I mean by this. Posterior teeth touch simultaneously when the patient closes. In other words, everything hits. Okay, when force is applied, it's directed down the long axis of the tooth. Front teeth are going to have slightly lighter contact when they first close for me. And I came to that by designing occlusions, putting them in, and realizing that in almost all patients, when I set them up and had them tap, they would tell me they were tapping their front teeth first. They would say, my front teeth are hitting hard. And yet, when I just had them tap, the forces were almost exactly the same. Well, what happens is there's a little bit of an arc of closure thing there. When people tap, they're usually not all the way at that seated position or wherever the reference was. They're usually a little ahead of it, wherever you designed it. And so they'll tap, and they'll feel that. And so I just lighten it up a little. For me, it's dragging AccuFilm through. Some people like to use shim stock, 8 or 10 microns, and be able to pull that through cleanly. Under clench. Now, once teeth touch, now we apply power. Neither teeth nor jaw deflect. Nothing's going to move. Well, that's not fair. The teeth are actually going to be intruded a bit into the periodontal ligament. The periodontal ligament is there for that purpose, to take some of that force, okay? In movements away from that MIP position, we have to talk about something called guidance. And truthfully, in movements away are kind of forced movements. We're just gauging things to see what guides. In function, it's always going to be inside or outside in. In other words, it guides things in. We usually look at looking out. And when they bite down, where can they touch now? In other words, I get that we're looking at what guides in if they're going that way, but we usually test this by having someone close and then push out, and then sometimes pull back. But the question that I have for this is that when we talk about guidance, most of you have an immediate idea about what that means. And I would like to ask you if you've ever considered anterior and posterior guidance. And for most of us, when we hear the word guidance, we think of anterior guidance and anterior teeth, but there is a guidance that exists for these teeth that is a posterior one, and we call it the posterior determinant. It's the angle of the eminence. The condyle is going to move on this eminence, and the eminence is, well, unless it has been altered, there is always some angle. If it's a shallow, small eminence, it'll be a very small angle. If it's a very large eminence, it's going to be incredibly steep. If it is steep, then the back teeth are going to separate very quickly because it has a huge effect on back teeth. If you can picture this in your mind as that drops, boom, here's something up front touching, and this is coming down fast. Those back teeth are coming apart very quickly. If it was shallow, that eminence, as illustrated here, those back teeth are going to separate much more slowly. You're not going to see that much separation. So think about it like this. This is just from the anterior. We're looking in, and if the ball is seated and the forward position is where you see this coming forward into, and the teeth are going to come apart as you move from one position to the next one. The effect will be largest on second molars or third molars if you have those, and it will be get smaller and smaller until it is zero on the teeth that are in contact as you move forward, because those are the first teeth touching. Behind that, everything is opening up. Laterally, if we do a lateral excursive movement, it's going to be forward and at an angle. And then teeth have to cross over each other. In fact, this is one of Dr. Henry Tanner's drawings. He said posterior tooth form is designed to allow cusps to move through or past as they escape the occlusal tables. And that was the drawing that he created. In fact, one of the exercises that he often had us do, we would go in and we would design something and he would say, what's going to go through there? And we would think about, okay, do those sit there? In a class one occlusion, we have an idea of what's going to pass through those always as we think about it, which means we can then consider when it's not class one, we still have to have some things passing through, but they're going to pass through differently. The posterior determinant is fixed. I'm not a surgeon, so I can't alter that. An oral surgeon could alter that. And there are people out there who have had eminectomies and they're flat. And as you can imagine, trying to make a stable occlusion for them can be difficult because you almost have to create like a flat surface on a flat surface. The anterior guidance then is whatever happens ahead of those condyles. That becomes the anterior component. Now, for us, almost always, that's going to mean this. I try to establish this as much as I can, and it has to do with force, but that's the anterior guidance that we usually mean when we talk about anterior guidance or guidance. And it's the little thing that happens right up in there. It's when the front teeth interact with each other as back teeth separate and the condyles, the mandible, moves forward and therefore down the eminence. That is changeable because it involves teeth. Teeth that can be moved or teeth that can be altered in form. The greater the angle, the greater the force. The flatter the angle of guidance, the lower the muscle activity was determined by Williamson years ago. Weinberg put some numbers to it. For every 10-degree change in the angle, there's a 35% change in force applied to move on that. So the steeper something is, the more muscle force will be applied just to move on that angle. We know today that there is no relationship between these two because one is one way in the front and we see that in the joint. We can't relate those two. It's totally random on whether you'll have steep, or shallow, or anything in between. Why would you do it on anterior teeth? And as I said, it's because of bite force. The forces are tremendously different that you can apply. And if I can get back teeth to come apart, I cannot apply the same force across the system. If back teeth are touching, when I can go side to side, as we know, you know this, they wear actually pretty fast, and I can break teeth. So canine guidance was kind of designed because it helped teeth stay around. Now, is that what nature does? Well, if you look at multiple studies, I mean, the answer to that is yes and no. 2.3% of the time it occurs bilaterally in a natural untouched occlusion. 10% of the time is unilateral. So I'm going to say, yes, that is what works 13% of the time in nature. So why would we try to create that in restorative dentistry? And we're going to blame Clyde Schuyler. Clyde Schuyler is a prosthodontist in New York City, 1929. He wrote an article actually, and he had been working with people with lots of money trying to help them keep their teeth. So in 1929, you can imagine in perioprosthodontics, they'd had periodontal treatment, would have been surgery and tooth extractions and periodontal kind of press, but they had to build roundhouse gold and put facings in them, acrylic facings. And what he said was in his article that what he discovered was is that rather than denture occlusion, which would have been full group function, he said I started having them hit only on anterior teeth and they destroy the prostheses much less quickly. Um, so we really started using canine guidance for prosthetic convenience, and we use it whenever the situation permits. It works. By the way, it doesn't always work, as you know, and why we have to shallow things. So here's the question that you would ask. If we're going to go in and design an occlusion, depending on the pattern someone has, can it be altered? Because Lundin and Gibbs found out that people have three different sorts of patterns. There were vertical chewers, there were horizontal chewers, and there were people who were variable, who did some straight and some horizontal. Um, these were discussed kind of over the last number of years as cows and rats, and then it became cows and gators. But let's just say you get the picture, and I know you've heard this one before. Can that envelope be altered? In other words, if I go in and I change how the teeth are formed against each other and I change what they have to move against, will it change their ability to function on those? And it turns out that it can be, yes, as long as it's just the chewing envelope. In chewing, it still worked. In the envelope of function, patients could chew fine. All of them could chew fine. It did not disrupt their ability to eat. The question then really became the envelope of motion. Will they still move dysfunctionally in brucks? Will they go to things that are not involved with them eating and wear teeth or break teeth? The real question is, can a neuromuscular envelope of motion be altered? Can we change that one? If they can go do something, will they still do it? This is probably the first study like that, although it's been repeated a number of times. This is Eckfeld and Carlson. They took 11 patients with broad pattern and edge wear, and they restored them in narrow patterns. In other words, ideal anterior guidance, overbite, overjet. And at 3 years, 6 of the 11 were successful. So there were 5 failures. The 5 failures destroyed teeth. They broke them, they wore them, they knocked them out. Okay. So probably that rate is not good enough. Okay. So if it's the envelope of motion that we're thinking about and they can still do that, we changed it, but they can still go outside those and do things that would destroy things, the answer then becomes maybe. And because that number is not adequate for a restorative dentist, at least like me, to say, well, fine, I'll just do it and half the time it'll work. I can't do that. What I would love to say is, why don't we try it? If it works half the time, let's go try things. So you provisionalize somebody who you're going to restore. You might make it look like that, and you may wind up, if it doesn't work, they begin to have teeth get loose. They begin to knock off provisionals. By the way, my recommendation would be that the provisionals mimic whatever the final restorations would be. So individual crowns. It becomes a test that the patient and I get to do together. And if it doesn't work, I have to change it. So I have to change the length and the steepness of things in a way that allow the forces to be shared across a big enough area that they don't cause changes that will cause the case to fail. So I have to try it. And I believe that if you've learned anything about wear in your lifetime, if you've been doing this long enough, what you learned is that the patterns that you apply the force across are very different. And sometimes that would work. One of the nice things about the discovery that bruxism can be precipitated by breathing issues was that if we could figure out the breathing issue, a lot of those people no longer did this really intense bruxing. Awesome. That means that some of those people, when we altered what they had done, would not have the need for having it changed. In other words, making it shorter. They're not going to knock things out anymore. And that's been a really wonderful thing that's occurred in my lifetime. So in a mutually protected occlusion, canines are the guiding teeth. As I said, we always check it out. We have them slide out, but function is always down and in. Okay, if we're looking going out, we slide them out, and there should be a shift to the incisors. In other words, the contact moves on the canine, and as soon as we get to the tip of the canine and get past that, we're going to be on the front teeth. We can be on the central and the lateral, or just the central. This kind of function is guiding things in, but in people who show us functional wear, it's not just functional wear just from chewing. They're probably doing some things in those areas. So we can't use it when forces mandate assistance from other teeth. In other words, I need some help. One like this where there is no place to guide over there. If I guide on the canine that is over there, then the molar on your left is going to be the thing that comes off. And the way that I would have been taught to deal with something like this, there would be a telescopic crown on that molar. And I would seat this because you can see the rotational situation that's going to occur. It's going to want to pull it off. And so we would cement that, but we would expect that it might move. And so we would probably protect it. So that if we had to do something, okay, at least now we're functioning with two crowns against each other. They might break loose, but you can often get enough movement, and the contact there is going to be spread out across the arch. I'm not going to build it right on one tooth. If I can spread it around the arch, the more I can spread it out, the lower the force will be trying to lift it off of that most posterior molar. If I have a structural deficiency, I don't have a choice. I can't guide it on the canine. If I have inadequate bone, because the canine is going to move. And then if they brux, because if they brux, and I know that they're bruxing, and I haven't discovered a reason why have established a belief that they will stop, if I give them pointy canines, I'm going to get broken canines. Some patients require force distribution. Group function distributes that force. Mutually protected occlusion is going to keep back teeth apart. And there's blends in between. For instance, if group function is appropriate, and it's full group function. And I'm not going to really consider function on molars. I'm going to try and stay away from that because of the forces that can be generated. To me, a full group function case, I'd have contacts on both sides until I got to front teeth, and that's what you see here. Okay, that's going out to the working side. Working group function, if I just did it on the working side to share that load, would look like that. You wouldn't have any opposite side contacts. If canine guidance is appropriate, I'm on the canine until I'm on the front teeth. And all I have in the back are dots. In other words, stripes in front, dots in back. No balancing interferences. Okay, that was a big one. Today, sometimes we think about balancing contacts in full group function. And that's what the premolar contacts were in that group function picture that I showed you. In lateral crossover, anterior teeth touch. I don't want to be on those molars. If I can shift out to the side and crossover and get on molars, I can split molars. I can apply a lot of force back there. And I had patients who did that. I want that to separate. And then in straight protrusive, I want to have smooth movement forward so that when I come forward, the mandible can move straight forward. In other words, the lateral pterygoids are not having to figure out where to go and design a pathway forward. So I love to watch for that smooth movement forward. Slide straight forward onto those edges. When you get onto those edges, it should be smooth movement easily. So here is my list of things that have to do with establishing a stable occlusion. If I can do all of these things, I have found that I will create something that will have the least force able to be applied at specific positions in that mouth. That minimizes the ability of the person to apply forces that would be detrimental. So how do you make the plan work in the mouth? You begin with the edge of the maxillary central incisors, just like setting a denture. You put those in the right place in the face. The next thing, I look at lower anteriors and pick what could work. Make front teeth work. If I have teeth to work with already, I decide what I'd like different. One of my favorite things to do is to look at the lower arch. One of the things that always occurs with them, what I would call the quintessential equilibration artist, is the orthodontist, because they can move teeth wherever they want and they move them all around. Then they have to make them function against each other. That's a form to me of equilibration, because my paradigm around the word equilibration is just designing how the teeth will interact with each other. Doesn't matter what you choose to do. And today that means sometimes reductively. So one of the things I love to do is look at a lower arch, because I've noticed as I got letters back from orthodontists, it always says align and level the lower arch. So if I do that, I say, well, that one's really sticking out. So I would color it like this. And then I would see the rest are reasonably close, although you can see a little bit of variability right up front. I think that I would level it. And I haven't decided on those incisors yet. I will tell you what happened once I got started. Make the front teeth be right where you want them to be, on the incisal edge. Now start making them work. As I did that, I want you to notice that canine has been trimmed off. It is no longer in that flow. Okay. I want to go create smooth. I want movement that allows smooth movement as I come across. Sometimes it's going to drop in. Dropping in is fine as long as you can escape. If you can't escape, then you have to make that contact that occurs as they're coming back be a round surface again to round surface, so it will move. In this case, it bangs into it. And you can probably tell if you look at the mesial incisal point of that canine that could be reshaped and reformed and actually can lift it right back out of there. And it will do it very smoothly. On the other side is one that took way less to adjust. Here it shifted immediately as it came across. By the way, on the other side, Had I thought I wanted longer centrals, can you see that I could have built something that would shift very easily right across? So this side is showing you what happens when that's in harmony with each other. Okay. Here is the pathognomonic lesion of crossover. This is a really old slide, so I apologize. It's very pixelated, but there's the locked in position in crossover. Remember, smooth is the most important thing. Imagine I give you two marbles. I put a flat spot on each marble. I have you squeeze as hard as you can. How hard can you squeeze? Well, hard as you can. If we turn it around and I have you squeeze with two rounded surfaces against each other, always, at some point, they are going to fly apart because it moves when you apply the force. When that happens, you can no longer provide the muscle force. Your muscles have to stop pushing. Now, I realize they move a little bit, but they stop. That's the same thing that happens if we're looking at teeth. This person now, when they apply force, can't lock. When they can't lock, they can't do the same things to those teeth. If they keep doing this, do I think that someday they could wear that in there again? Absolutely. I believe that could happen. However, I believe it's going to happen much more slowly now because those muscles can't lock up. Once I have front teeth that are in the right place aesthetically, okay, and I like them, upper and lower, make the back teeth work once the front teeth work. We make the back teeth work, we go in and we just tap, tap, and we see where are we hitting. If you have total control, if you're waxing, you just wax it up. Wax up what you want. Get the uppers where you want those aesthetically. Set the upper six, go and have wax the lower six, make the edges work against each other. This is what you do kind of with the denture, you would make the edges work. Then go put back teeth in there based on where those front teeth are in the correct position. And here is what that looks like. Interestingly, if you look at the central incisor on the right side, patient's right, you'll see that some wax had to be added there for form to be able to get an initial contact there. And I love to say this today, the names for our preps have left us. I'm not sure what that's going to be, but you could have gone down and adjusted the lower, whatever your decision was, but this gives you a guide of what has to happen, what has to change to make that work. And on the patient's left side, as you can see, those linguals, which are the functional cusps, are all in a place where they were able to work. So once you have that and you have it all working, you could design all of it because you had the ability to design all of that, except for the second molars. If you have all the teeth there, you look at where they touch. Here's some dots. There's some adjustments to the dots. By the way, these are great dots, but since they're the only dots I have, they're the only two dots, I either have to change those or I have to change all the rest of the teeth until I have those dots and dots everywhere. Now, I could have done that additively. In this case, we didn't. And this is from Frank Graziano. This is one of Frank's patients. We did it reductively. And it's a case that now you can get dots where you want them. Now, they're not necessarily the picture perfect dots you'd get everywhere if we waxed, because these are natural teeth. If we slide around, what we're going to see is it didn't change any of the blue dots in the back, and we have stripes in front, which means we have anterior guidance on anterior teeth. What if you're doing this in the mouth? Here's a calibration of the natural dentition. There are rules. You probably learned these rules. There's a Lobel rule, the Muddle rule, and the Bull rule. And I remember memorizing these and then going in, and I'd think through each time what I was looking at. I have to tell you what I've come to. I don't think about the rules. What I look is I look at the teeth, I look at the tooth form, and I go in and look at the marks, and then I grind in the marks that are there. I adjust those. Now, while I'm doing that, maintain natural tooth form. Adjust the tooth that will be least affected by this change. If there's a tooth that is sticking up and I know that I want to alter it, reduce it. Have that be the one you pick. And then my recommendation, what you want to do, have patients grind in red, have them tap in green, blue, or black because it covers red better. And you get to see functionally what is happening for them. Step one, adjust end-to-end and crossover excursions. Adjust so both centrals connect end-to-end and protrusive. In other words, there's nice straight movement out to those edges. Adjust the form on those edges and on the lingual surfaces so you get that as you go back in. Okay, that's if you're coming to front teeth first. I realize that we may not have done the back yet. Okay, sometimes if I'm changing anteriors, I get those edges right where I want them first because that's the end point of the movement and I've just established it. Okay, now I have some choices. In this case, I'm going to work just on edges to start. Move to extreme lateral and protrusive excursive, smooth out steps, catches and crossover. Okay, all of these things. And Josh, I saw that Josh raised his hand. I'm gonna say, could you type a question in for me? because I'm happy to answer any question, but I'm almost wrapped up. Okay. Don't forget protrusive crossover. Don't forget that. Don't get locked in here. By the way, when people who play here have those lingual incisal edge fractures on the lower, create even posterior contacts in CR on all posterior teeth. Now, this is going to tap tap. Once you know the edges work, okay, I can get you on the edges. Now the teeth are in the right place. And by the way, you could have done this one first. Please don't hear me wrong. I chose this because those front teeth, the edges were being modified. In this case, we weren't changing her front teeth, so we did the tap taps first and then went to grinding. This is Frank's case. This is the one you saw the models of. Okay. And here the tap taps were all accomplished before any grinding was done. Once you get this done, so I've got all my tap taps done, now I can start moving things around and judging the excursive movements out to my edges. Okay. In other words, I want to get dots where I can get them if I'm dealing with teeth that are already there, because I don't have control over those. If I have control, I can design whatever I want in there. I always stop when the canines are in contact. Actually, I stop when one is in contact and I begin to say, okay, I've anterior coupling now. What do I have left to do? Because I may want to consider some additive things to do, because that might be an easier solution. Eliminate lateral contacts on posterior teeth. Start moving things side to side from that intercuspal position. Protrusive contacts on posterior teeth. Move to dots in back, stripes in front. And this is a different case, but you'll see that we have all the dots in the back and we have stripes up front. So the front teeth are in contact. By the way, the stripes are not always going to be perfect. It's going to depend on the form of the tooth that is opposing those anterior teeth. Then check and smooth the harmony of the anterior guidance. It should be smooth movement. If the patient stops in a functional movement, they're running into something. And so I have to go look at what they're running into. By the way, they will help you. I will literally watch them. If they stop, I'll say, did you feel that? They always did. I can now go in and see that and see what is it that is hindering them just moving smoothly when they fire muscles. They're having to fire more muscle to move. And you can notice that. That's called harmony. Smooth harmony allows them just to move right out onto those edges and then go back. Postural freedom. I like to sit the patient up once I have dots everywhere. Got my stripes, sit the patient up and do the dots in two colors. And on this one I'm illustrating, get a black dot on your left. If I then put red in, I'm going to get a red mark because that patient is arcing forward a little bit. Even though if we seated them, if their condyles were fully seated in that, they're going to hit right where it hits. But I want to clear for the arc of closure as they're tapping. And Pete Dawson named that long centric. There's a little place there where you can move back and forth. Then reevaluate everything, look at everything that's there and go and polish it so it's nice and smooth. People will mostly notice rough spots from your adjustments. So you want to be sure to polish. Diamond polishing paste, you can get things as smooth as glazed porcelain. Okay, once you're done. So I know that was a short thing, but the idea of it was to say that making teeth work against each other is not difficult. And if you're thinking, what do you mean it's not difficult? And I've been struggling with my whole life. Yeah, me too. I get it. So let me not use my quote. Let me just say that somebody asked LD Pankey many years ago if he would just write a book about occlusion. And he said, it would be a really short book because occlusion is simple. With the condyles fully seated in the fossa, all the posterior teeth touch simultaneously and evenly. The anterior teeth touching slightly lighter than the posterior teeth. When power is applied, no tooth moves and the mandible does not move, other than compression into periodontal ligaments. When the mandible is moved in any excursion, no back tooth hits before, harder than, or after a front tooth. And he said every possible design is in that. So occlusion is simple. Now you just have to learn when to apply those principles appropriately to each individual patient you have the privilege to serve. It's simple. It is not easy. So I'm sorry I went a tiny bit over. I apologize for that. I am very cognizant. Focused courses. This one is Mastering Case Acceptance that I get to do with Todd Davis and Amy Heim. And it is taking you to the question. Can you find a way to stay in the question until the questions come from the patient? There are some skills that you can learn in order to do that. And that's what we work on this 2.5 days. And then this one, Mastering Business Essentials with Mark Clive. Mark and I and Robin Reese have been doing this for a number of years. I got to take Rich Green's place. Rich did it for many years. And before, when I was here from '03 to '08 at the Pankey Institute, Rich Green and I used to do one we called business, actually financial management, but it was really the same workshop. It's understanding the numbers in the business in there. And then this next September, I'd like to invite you to one that I get to do with Michael Schuster. Michael Schuster developed the Schuster Center. He no longer is doing that. In fact, that's now 7 years ago since he stopped doing that. And he and I had become friends while he was here in Phoenix. We talked and I asked him to help me do this. There will be several other people there helping, but Michael and I are going to do this initial one. The idea of this is to show somebody what is the blueprint that he developed for success in a practice. And so it's the overall picture. There are some specific focus things that we give you some tools to take home, but it outlines what is the process that allows you to create whatever practice you want. So with that, I would like to go to a QR session, and I'm going to escape this and stop sharing so that I can see and go see if there are any questions. Um, so the thing that's on the screen here is, so Mary Cellino, if I'm saying your name right, thank you. I apologize if not. Truly a brilliant lecture. Wow, that's pretty wild. 223 people are here? Holy cow.
So we do actually have a couple questions. They're all in the Q&A
I'm
section.
going over there right now. Okay, here we go. When you alluded to variability in the number of contacts in MIP, I think you meant across different patients, but have you encountered any significant variability within the same patient at different points prior to alterations? Well, yes, because anybody who does not have a fully seated condylar position as the reference can move around. And very often, as you change something, they're going to go look around for what fits well. For yeah, the dots will change, and that's why if I can't use that fully seated condylar position as a reference, then I have to use existing teeth as a reference, or I have to create an appliance for them, let them wear the appliance. By the way, the appliance could be full provisionals, because that to me, that can be an appliance. I'm going to go and I'm going to alter this until it is comfortable and it is functional. And therefore, with this one, and so yes, they can move around. When I get to the point where they're not moving and they have a stable point, so they leave with a certain number of dots, and when they get back, I go tap, tap, and they have all those same dots. Now I can capture that relationship. And when I finish a case like that, because I can't seat those condyles and use that as the reference, I can't finish the whole case. I have to keep enough teeth so that I have a reference. Okay. I hope I answered that well. Um, Andrea, hi. A change in engram is resolved doing dentistry on the first point of contact. I run into issues where a terminal tooth in the arch is the first point of contact. Temps came back totally fine. Crowns are too high and I'm grinding a lot and often sending them out. Um, yes, I can. Because I've had exactly those people. What they're doing is they're adapting to that engram. It's working. The time that they're hitting it is not when they're there with you. So I find these are people, if you deprogram them, you can find that first point of contact. And therefore, are they just deprogramming closer? So I would argue that those people were not at a con, fully seated condylar position. Okay, they're forward of that. And they work there fine almost all the time. They weren't doing anything. But there are times when they go back and can hit it. And sometimes they can come back and show you that. They can't always show it to you. They'll come back and they'll tell you it's high, and you can't ever find it high. And some of those are the kind that can develop into an occlusal dysesthesia. So I don't have a good way to fix that, except here's what I love to say. Every person who comes into your practice, find a way in the exam to put a leaf gauge in there, try to deprogram them, and try to see where they touch first. At least now you can tell them about it. Okay? All right. I hope that was helpful. What thickness articulating paper do you use when you were checking occlusion? So I love Madame Butterfly silk. It is thick as typewriter ribbon. And I use 2 reds and 1 green, which means I get piles of ink. That means, though, that what I can now do is, once I have somebody grinding red and tapping green, I can have them grind with nothing in there and tap, and I can go look for white dots in the red and white dots in the green, and that will show me what actually hits, and it's why I love it. it's a mess and it's all over the patient and all over me by the time we're done. But I use that when I'm working with occlusal issues and bite splints. I love it for those things. When I'm putting in dentistry, I never use it. It's a mess and it marks everything. AccuFilm is what I love when I'm putting in a case. All right. How long do you keep patient in temps to see if the design works for them? Well, my minimum is 90 days. And I don't know how I got to that. I think somebody told me once you needed at least 3 months without having him destroy everything you do. And that kind of stuck with me. I don't have a good reason for that. I'm not sure how long you need. I mean, if you put them in and they're all the way it would be when it's done and you're not noticing anything contrary, and I got to believe if you waited something like 6 weeks and nothing was happening, I'm guessing it would probably be fine. But somehow I got tied. I got into 90 days, so 3 months. And so that's my answer. I don't have an answer for why it's the right answer. It's just the one that I live with. Can you keep canine guidance if your maxillary canine is a single implant? Thank you for asking this. You may apply lateral forces on this crown and it can fail. Actually, you probably will apply lateral forces on this crown because you're going to treat it like a canine. So there's some neat things that have happened. Most of the talk about making sure never to include only that canine as a canine, in other words, you had to share the load, was that they failed. But the failures almost always were screw failures. The screw got loose. And today I talk to a lot of people who say that if you're dealing with the internal hexes and or a Morse taper, you don't need to be restricted by that. And I have done a number of canine implants that I now just treat like a tooth. And I'm not afraid to build canine guidance on those. Now, those were patients who didn't show me any evidence of doing a whole lot of stuff with their teeth. If they're doing a whole lot of stuff with their teeth and I had seen a lot of wear, I probably would just include what I normally would anyway and distribute some force because I know that that will reduce the force they can apply at any one place. A frequent point I recall being brought up in school is that the canine had a long route that distributed forces and explained why favorine guidance made sense. Evolutionarily, was the canine just long rooted to help bite into things? If so, I am more compelled to let canine guidance go more often. That's a wonderful question. Actually, if you go read all of D'Amico's articles, because he was the guy who kind of developed canine guidance, you know, it was really interesting. When he called it that, his guidance was about them coming into the arch in a way so that they could be used as grabbing and shearing teeth. And he looked at all the primates and had the spaces that developed, because you had primate spaces other than in human beings behind canines. And it had to do kind of more with what you're saying, I think, the grabbing stuff. It turns out that I think that I believe, because I have built some people who didn't have canines that touched in a seated condylar position, and that's where they were comfortable, that they started out on premolars, and those people have done very well. But I would argue whenever I can get canine guidance, yeah, I'm going to go there. I am not as afraid to let it go as long as the case tells me I believe that could work. And because of that, I would argue that, you know, what you're saying is probably that's probably what I'm thinking when I'm thinking that. So thanks for asking that. Class 2, Div 2. Yeah. Okay. Class 2, Div 2. Well, first of all, Class 2, Div 2 people, if they've developed like that, a lot of times they do just fine with those really steep guidances. But if they're locked in there, here we go. Okay, don't get locked in here. I'll come back to that. It's not that locked in. And they're pushing out forward, you're going to see stuff happening. If nothing is happening, there's nothing wrong with restoring them where they are and because they're not doing anything to destroy those. If they're destroying them, I have to create more freedom. Very often in class 2, div 2, we see that stepped occlusion. And one of the ways to treat that stepped occlusion is actually to kind of change things. We can open vertical dimensions or we can intrude lower anteriors and change the angles that things have to move over. And when we do those things, I think that we can unlock those and change the forces they can apply. So I hope that helped. You said don't get locked in here a few times and alluding to excursive positions. I'm not 100% sure I would know whether someone's getting locked in. Is this a matter of whether the slopes of the teeth are too steep and hard to overcome by the muscles? Yes. Here's what I watch for. First of all, the pathognomonic lesion at crossover is those triangles, upper or lower or both. And if you watch the patient come out and shift over, they lock into those. And if you ask them now that when they go there, hold there, you know, don't hold hard there. Can you, if you apply force squeezing into that, can you move? Does it move? That's how they're locked in. They can lock it up if they want to. Now, if they release a little and try to slide, they do, but they usually have to release a little. That's what I mean by locked in. How do you treat a pathological retruded contact second molar case? Well, if I have, well, it all depends. Tell me what's happening on the second molar. If the second molar has wear and there's no wear anywhere else, and then in maximum intercuspation, all the teeth touch, but only the second molars are worn. By the way, it's usually accompanied by a super erupted maxillary molar that has erupted down and out, because that's how they erupt. So you have the lower dished out. First thing I'd be thinking about is, in my head, I make the lower tooth look like the tooth that it was. Then I say, where does that upper tooth have to be to work against that? It's usually going to be back up in there. And then I got to figure out a way to have all the teeth touch at the same time. Usually that means trying to find a way to work at a seated condylar position because they're going there and they're loading those teeth up. Okay. So I would call that a pathologic retruded contact because it created a lot of wear. Okay. Um, if the patient is on board, would you recommend doing ortho, including extrusion, to get them to a place where they are stable first, then just do restorative work for aesthetics? Absolutely. I think ortho is a wonderful thing to do. Yes, I'd love to move teeth. If I see someone who I would love to be able to work at a fully seated condylar position, and if we fully seat their condyles, I'm either going to have to do a load of dentistry to make everything work. Yeah, I'd much rather move teeth. So anytime that I can reorient the relationship of teeth to get the result that gives me what I want, I'd be saying, yeah, let's do that. And then less dentistry is always good on the teeth. That's going to help them keep them longer. Hi, Matt. Gary, what do you recommend when you deprogram and the condyle goes forward, indicating a constricted chewing pattern? Well, this, how far down the rabbit hole do you want to go? Here's the thing. My goal is going to be to make teeth function the best they can against each other in a position that the patient is able to use and not destroy their teeth. So because this person is wants to be forward, I am going to try to free up things so that they can hit everything they need to hit there and move around from there in some smoothly and comfortably without applying excessive forces or trying to wear things in. Sometimes you have to give them two bite relationships. And this is way further down the rabbit hole than I wanted to go. Years ago, we used to talk about people who had a Sunday bite and it was a forward position. And we used to say that position was because, they wanted to be out there because they function better there or they look better there. And I'm sorry, because they look better there. I have since discovered it's because some people function better out there. Today, I think airway plays a big part of that. I can function better if I can breathe. In fact, if you can't breathe easily through your nose, and some people, when they seat all the way, they can't, it restricts things. When that happens, you can't swallow normally or chew normally. And so there's a whole lot of things that can happen as you try to adapt. So I would argue that I have to find the place that the person can function well. I would do some tests and think about some other things about, are there other things I could alter that would make that be a less constricted chewing pattern for them? And that might mean changing how teeth hit each other, or it might mean changing something else, maybe getting them breathing through their nose. Okay. So that was further down than I planned to go in an hour, and I'm already way past an hour. In aligner therapy cases, all occlusion is changed. What happens then? And from that point forward, how many of these cases become problems? I don't know. I guess that if all occlusion is changed, you're starting from scratch. And so probably I'm going to argue most of them work, or people would have stopped doing aligner therapy to move teeth. And most people adapt to the changes that are made. I would argue that what you want to just think about is, I'm going to put teeth in a way that they work well. I'm going to start out by putting the upper anterior teeth in the right place aesthetically. I'm going to put the lower anterior teeth in a correct aesthetic place, knowing that it's a variable, because I can vary what is aesthetic on the lower. And I'm talking about that even in the apical cervical direction. And then I'm going to close the teeth and have them hit each other. And when they hit each other, that's my vertical dimension. So I would just argue, I'm going to put them where it looks like they will work in this skeleton, and then I'm going to see what happens. Most of the time, I believe that works. Thoughts on maxillary anterior guided orthotics. So I'm not exactly sure what that means. That means an anterior guidance full coverage bite splint to me. And that imago, I think, is that you're getting you're out on the front teeth, right? And sometimes those start with no posterior contact, so they basically make it a thing out front that you just function on, and then they add back teeth after you have deprogrammed. I would argue that yeah, they work. It depends what you're using it for. Um, all appliances work as long as you tell me what you're using it for. And I think that the reasons that Magos get used, as I understand them, they can work very well for. They deprogram, and then they can give you a position that that person could function in. Gary, nice letter. Hi, Philip. I think we met at some point at the Institute. I attended what was then C1 through C4, 88 to 92. Yep. And then the last of the Dawson Philosophy Weeks. Retired, now enjoying lifelong hobby. Oh, so just saying hi. Thanks, Philip. Thanks for being here. I appreciate it. Enjoy retirement. In what case do you use muscle deprogrammer appliance? So this is not going to be a joke, and I'm not being flippant, Jojo. Whenever I want to deprogram the patient. Now, that's not being flippant. I'm going to give some follow up to that. If I have somebody who has muscle discomfort, lots of muscle discomfort, and I don't know why it's uncomfortable. Are they trying to go somewhere? Are they overloading things? I'm just going to try and turn things off. And the easiest way to turn that off is to give somebody something in the front that hits flat in the front. And when they move, there is no vertical movement. If you move around like that, it takes the least energy, it takes no muscle. And therefore, you don't have places to apply lots of muscle other than clenching only on the anterior teeth. By the way, most people can't apply as much force if they can only do that on front teeth. So for me, a deprogrammer is designed specifically to shut off as much muscle as possible. And then I can begin to change how things hit, and that begins to play into the what is happening here and what is involved. In other words, what can I correlate to something that I now can have them feel and get back to? Okay. Dr. McDivitt, thank you for being here. Uh, by the way, this guy knows so much more than me. I've learned so much from him. It's awesome for me. And so I'm gonna interesting how applicable to a patient with periodontal disease who requires the same principles to heal and have reduction in the susceptibility. Any other thoughts? You know what? What I love about the things that we're learning is that all the stuff that happens, not just to teeth, but to the systems around, if we want to create a stable situation to allow adaptive healing, orthotic, orthopedic stability is vital. And that includes teeth hitting each other and what happens when you rub them against each other, because it's what we do. And if we can apply more force than our system wants us to be applying, and that gets read by us as doing harm, we experience it as pain, or we experience it as fractures to teeth, whatever happens to teeth, including getting teeth moving, okay, and exacerbating periodontal issues. Then I think it just is so clear that it is so important. Occlusion is really, 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 really important. And then I can say today, and I say this with pride, I don't believe it causes temporomandibular disorders, quote unquote, because it doesn't. Teeth are followers. However, there's all kinds of things that can do. By the way, that is the subject for a whole nother thing that I spend about an hour and a half on that is called What is the Connection Between TMD and Occlusion? And maybe I can come back another time and we'll do that one. Fred, hello. Thank you for being here. Also, I was thinking of you just last week. I was talking to some Michigan people and your name came up. Thank you for being here. Go blue. All right. What would you recommend, Shanlin? What would you recommend for someone who's lost so much vertical that they don't show teeth when smile anymore? Will you increase the vertical incrementally? Actually, this one is easy for me. Thank you. That's a wonderful last question. Okay. Put Imagine, here's what you have to imagine in your head. This person has no teeth. Go put teeth where teeth go. How do you do that? You look at repose. Okay? You look at a smile. You go in and you say, where do the teeth go? Both in the from the anterior in the vertical position. So apical, coronal, where do you put this? Where do you set the front teeth? Set it like you're putting in the two central incisors on a denture. Put them there. Now go to the lower arch and go and look and say, okay, where would teeth go in a denture down here? How would I put them there? How do you position lower teeth on a denture? You do it aesthetically by saying, okay, well, here's where the lip is, and I got this here. And then you do it by speech. You have people talk and you see what happens. That not when you have them close those together, that establishes the vertical dimension. Also take into account the anterior posterior position from the lateral side. I'm going to look out here at a sagittal view. There's a position I'd like that in, and that becomes important a lot more than it used to be for me. I used to just say, where's their bone? Today I have to say, where does this go? So that I can have the teeth in the right place so that people have enough airway exposed. But I think the vertical dimension is going to be determined by the teeth in the face. If you think about this, the dentures on patients who wear their dentures down to almost nothing, do you open them incrementally or do you just put the teeth where they belong and you say bite? And by the way, almost 100% of those people will adapt absolutely to those teeth. The practice they can do to make that happen is to have them go home and read out loud. In fact, here's the test thing that you can have them read. I used to have this laminated. If you can fill the unforgiving minute with 60 seconds worth of distance run, yours will be the earth and all that's in it, and which is more, you'll be a man, my son. Every syllable sound in the English language is in that little paragraph. If you can get a patient to be able to say that clearly, they will adapt. The only thing that happens when you open the vertical too far, as long as you have put the teeth in a functional aesthetic position in their face, in their head, is that they can't talk. It never hurts because if the teeth are in the right place in the skull, I can't hurt them by getting them there. So think about it that way. Make them look right. If they look right, they almost always work right. Form follows function. Function is created by appropriate form.